Today I chose this topic of interest. It's a deep topic, but we will try to make it simple for everyone, okay? For those who doesn't know me, my name is Dania Bamefleh. I'm a glaucoma consultant at KCASH. The outline of the talk is we're going to go through a brief introduction about the uveitic glaucoma, and we're going to understand more about the pathophysiology, the diagnosis, and the clinical presentation, and we will enumerate and see together the signs of glaucoma, and therefore management. And if there's some time left, we can go through the cataract surgery pearls in uveitic cases, and just a short summary at the end. So glaucoma is one of the most potentially devastating complications from uveitis that can start initially with very simple anterior reaction and then ends up with blindness. The prevalence of glaucoma in eyes with uveitis is found to be between 10 to 20% in most common in acute attacks. However, in chronic uveitis, it can reach up to 50% of those eyes. So, as you know, to have a normal IOP, it's an equation between the production of the aqueous humor and the outflow. So usually the eye in normal situation, it is at balanced equation among the production and the outflow. So whenever we have any interruption of this equation, problems start to happen. And as you know from this figure, that the ciliary body is the factory of aqueous humor, and then it passes from the posterior chamber to the anterior chamber through the trabecular meshwork, and this is the trabecular meshwork pathway. The pathophysiology of the uveitic glaucoma, and initially what happens is a reduction of IOP because of the inflamed ciliary body, and therefore I would have hyposecretion, and also I will have a more increase in the uveoscleral outflow, which is the non-conventional pathway. So whenever this happens, you will have a reduced in the intraocular pressure. Let's focus on this slide. So this is an H&E stain slide showing what? Trabecular meshwork, yes. What's wrong with it?
Pigmented.
What are those cells? They're lymphocytes. So this is a packed trabecular meshwork with lymphocytes, as you can see on this H&E stain. And this individual, what do you think his condition would be? The cornea, anterior chamber?
Capes and
Chorotic precipitates, yes, that's right. And also anterior chamber cellular reaction. Okay, so over time, so initially we said there's a reduction of IOP. Over time, there are multiple complex mechanisms that raises the resistance to aqueous outflow, and therefore these patients would suffer from elevated IOP. So we'll go through each mechanism. We'll start by the open angle glaucoma. Usually it happens because of mechanical obstruction or dysfunction of trabecular meshwork. And also, these deposited materials can be either inflammatory cells, proteins, debris, fibrin, and all of this results in obstruction of the outflow facility. Also, the release of cytokines by the cells or the inflamed cells would exacerbate that, and in later stages, it can cause even new vascularization. The secondary angle closure mechanism, it can be either accompanied with a pupillary block picture or a non-pupillary block presentation. This is a photo showing what exactly, what are we seeing here? Extensive posterior synechiae, right? It's like reaching 360 degrees all over, and therefore you would have the iris Bombay figure, which is the diagnosis of acute attacks or acute angle closure attacks. Secondary angle closure could also come in another form, that is the non-pupillary block. In those individuals, you can see that inflammation and edema would cause the ciliary body to rotate and making it migrating forward, and crowding of anterior chamber will happen. And this is the definition of what? It's like which disease? Plateau iris. Plateau iris, okay? So this is a non-pupillary block angle presentation. Now, the development of peripheral anterior synechiae is also another cause of angle closure in most of chronic anterior uveitis. The characteristic thing about the peripheral anterior synechiae that they are broad and they are like zipped-like. Okay, so they are zipping the entire area between the cornea and the iris. And also, so we discussed the primary mechanism that was open and closed, and also the treatment of uveitis can cause glaucoma as well, because treatment can elevate the IOP in those people. Why do you think that? Does it happen to everybody taking steroid, topical steroid? What do we label those people? Responders. When can you define somebody with a steroid responder? What is the definition? I cannot see who is talking. Can you raise your hand?
And those who, if we stop the steroid, the IOP would return to normal.
If you stop the steroid, what will happen?
The glaucometric change will stop the
No, but what's the definition of a steroid responder? Somebody with a raised intraocular pressure after administration of steroid, but for how long?
2 weeks or more.
2 and beyond, that's right. So 2 and more weeks. It can happen at any stage, and usually it happens to, there are risk factors for people that will have a steroid response, positive steroid response, usually in those that have high myopia or have a connective tissue disease, and somebody with a pre-existing glaucoma would also have the same effect. Also, the chemical structure of the steroid itself can also play a role, like prednisolone, or like prednisolone is different from Lotemax, for example, or dexamethasone. So the structure of the component is important. It plays a role, the frequency, and also the route of administration. Was it intravitreal injection? Was it only a topical drop, and so on? Or is it even sometimes systemic? Right. So we further classify the steroid responder to 3 classes based on Dr. Armley and Becker. They suggested to make it high responder, moderate responders, and non-responders. Now, high responders are around 4 to 6% of the general population. Moderate response or moderate responders are somebody who is having the pressure above 6 millimeters from the baseline of IOP, but less than 15, while a high responder is like almost reaching 15. So high responders, as we said, is 4 to 6% of the population, and it's either defined as having a greater IOP than 31, or to have an IOP rise from the initial baseline for 15 millimeters of mercury. Moderate responders are about 1/3 of the population, and or having a definition of between 25 up to 31. Non-responders are 2/3 of the patient, meaning it's not that common to have a steroid response. So what are the symptoms usually the patients are suffering? They're suffering from photophobia. This will drive them to come to emergency room. Photophobia, pain, blurred vision, headaches sometimes, halos around the light, and sometimes even it's among the pink eye differential, so redness. Upon clinical presentation, you will have the signs of uveitis or suggestive uveitis, like cratic precipitates, for example, and band keratopathy in more chronic cases. Some sectoral iris atrophy that can be a cause of viral in origin, like what? Herpes simplex, and what else? Another category? Or another virus?
CMV.
CMV causes also this. Okay, good. Another common clinical presentation among those is posterior synechial development. As you can see here, it's extensive. Peripheral anterior synechial could also happen, and as we said earlier, it's like a zipped closure, and even you can see the ciliary body underneath. Posterior segment involvement can also be there in cases of uveitis. That could look like a cystoid macular edema, retinitis, like in this individual, or retinal detachment. What type of retinal detachment is this one? It's usually, which type is? Exuded, meaning there is fluid underneath the retina. Now, moving on to the signs of glaucoma on those individuals, usually they would have a high or higher than baseline IOP, and you can have, in chronic cases, you can have already established glaucomatous excavation of the optic nerve, and you can witness it as a nerve fiber layer, sometimes defect, or even visual field changes, pupillary block, peripheral anterior synechial. How do we manage those patients? I like to divide them into three main items that will help me to control those patients. So first of all, we have to control the inflammation, and second of all, you control the IOP, and last but not least, you have to treat the underlying disease. So controlling the inflammation could be by steroids, or what else? NSAIDs, that's right. So steroids, NSAIDs. Also, what else? Immune modulatory treatment in some refractory cases. Okay. So second line of management, that is to relieve the ciliary body. So we need to give them a dilating agent or a cycloplegic agent to overcome the synechial, to break the synechial sometimes, or prevent the development of synechial, and also decrease the ciliary muscle spasm. Okay. Immune modulatory, they're considered beneficial in cases where the steroids are not working or not giving the maximum effect, or if the steroids are causing high IOP. So you can shift the patient to a steroid sparing agent to control his inflammation and also to prevent glaucoma. So we'll move to the second line of management. We said IOP control. It comes in these three classes because they are the first line of treating patients, giving aqueous suppressants. Aqueous suppressants in this sequence is the proper way to manage a case of uveitis, starting with a beta adrenergic antagonist, and alpha agonist, and also, last but not least, the carbonic hydrase inhibitors. Can we use miotics? What about prostaglandin? You think can we use miotics, yes or no?
No.
No. Why?
It breaks the aqueous blood.
Okay.
And it will promote more synechial applications as well.
Yeah, it can cause synechial development, that's right. What about prostaglandin analogs, like something like brimonidine or etavoprost? Why? What if the eye is quiet? Very quiet, stable eye.
Quiet is fine.
Quiet is fine, this is true. So it's used, it can be, but it's a relative contraindication, except if the eye is very stable and was on maximum other medications already, like the patient was already taking one of the recommended classes, and still had above target IOP, you can start prostaglandin in those eyes, but never in herpetic eyes. Okay. Okay, sometimes we even have to use systemic medication in order to control the IOP, not only topical. Okay. So surgical options. What are the surgical options you think are the best for cases refractory to the medical treatment or has extensive severe glaucoma or visual field changes? The surgery of choice? Tube nowadays is taking the upper hand, that's true. Sometimes you cannot have a tube anywhere, so you can do a trap, right? Yeah. What do you think the success rate of a trabeculectomy? With the use of mitomycin, which is the new way of, I think nobody is doing trab anymore without the anti-metabolite, it is proven to have a better response. So it can reach up to 90% in the first 1 year and 80% after a couple of years. So you can start with a trap, okay, in those eyes. Why not DS? Fibrosis? You said fibrosis. Can we do a DS in uveitic cases? Yes, we do. Sometimes we do DS in uveitic cases, but not the ones with a zipped angle for sure, okay? So you mentioned earlier that drainage devices are of choice nowadays because of the higher success rate and the outcomes, and also we do not need to use anti-metabolite. And it has, in this study, they showed that the success rate of Ahmed valve was reaching 77% in the first 1 year and 50% 4 years later. And another study that showed that Burbelt or the valveless implants has also a good success rate reaching up to 92 for those patients. Laser. When is laser peripheral iridotomy indicated in those patients? In cases of pupillary block, that's true. And can I do it even in the presence of active anterior uveitis? If you have ongoing anterior uveitis also. What if like you started steroids and you bought the patient a couple of days later, pressure is 50? Yeah, you have to. True. If the benefit outweighs the risk, then you have to. And you can use like the deepest area. Usually what we do in those patients, because they come with acute attacks, sometimes even the iris is very close to the cornea, you're afraid of even hitting it. You start by the deepest area possible. There, you start hitting it, and then once you find that all the gush of fluid happen, you can wait for it for a while and then hit the peripheral corner. Sometimes we have to pre-treat it, pre-laser it with argon in order to achieve a large size peripheral iridotomy. Can we do it surgically? Yes, true. If it fails by laser, you can do it surgically, or if somebody has a corneal pathology, endothelial cell count that is low, or the visualization is not the best, you can do a surgical iridectomy or iridotomy. What about SLT? Is there any role for selective laser trabeculoplasty for those patients? Not enough studies, but majority of the time they are against it because their angle is already not properly working. CPC or transscleral laser cytophotocoagulation is reserved for the eyes that have a poor prognosis or eyes that you've done everything to control their IOP and still it is high. However, it's used with caution because of the risk of hypotony. Okay, so we use it but with caution, low power, not to treat all sectors. All right. Okay, so we'll move on to the second part of the talk. Inshallah, it's going to be a quick one. It's about cataract in uveitis cases. So the challenges about cataract in uveitis cases that it comes from what? Long-standing inflammation, long administration, use of steroids, and usually those individuals are young. So all of these are like risks for those patients. And also the proper thing is to control the inflammation prior to any procedure. So I have like a few, I find this article very interesting, I'll show you the link later, about perils in performing cataract surgery in those cases. So first of all, try to stay calm, expect the unexpected, meaning that phaco comes with its own burden of complication in a regular sitting, let alone a case that has a uveitis and high risk of inflammation. So you have to expect everything, expect aphakia, expect vitreous loss, expect also to have large iris tears and iridodialysis, because their iris is usually not in good and healthy situation. So you have to make sure that you have all the tools for your battle. So try by something simple like trypan blue, make sure it's already there, iris hooks, retinal scissors, capsular tension ring, and sometimes even we have to do anterior vitrectomy because some of the eyes are not ready to accommodate a lens because of risk, for example, of PCO. Wait for a period of time and make sure that the eye is quiet before your procedure. So what is the protocol for doing cataract surgery in uveitic eyes?
3 months.
3 months of
Quite
quiet eye, true. In some cases even more than 3 months, can reach up to 6 months. And you make sure that they are okay, there's no rise of IOP, make sure everything is settled prior to performing the surgery. Give the patient preoperative steroids, isn't it? Like it's usually we admit the patient 3 days prior and we give them systemic steroid with high dose in order to prevent post-operative inflammation. Okay. Do not use topical anesthesia alone. It's never enough because, as I told you, maybe you will need more than one surgery in the same sittings. For example, it can be combined with a glaucoma procedure or a retinal surgery sometimes even. So topical is not the best choice. You can add something like a peribulbar or a retrobulbar or even general anesthesia for young patients. Okay, and anticipate long time in surgery for those types of surgery. Now there is a very nice trick is use your tools very wisely. The viscoelastic cannula, you can use it to do what?
To break this.
To break what?
The synechiae.
Synechiae. Okay, what else?
Spatula.
Spatula.
Break this one.
What if it was too extensive? Sometimes it's not even at the pupil margins. It's reaching posterior back to the mid-iris. So you can use even scissors, intraocular scissors or forceps, and make sure not to hit the capsule or even injure the iris because it would cause more iritis and more trouble. So viscoelastic is a good tool. We usually go underneath whatever area that is has no synechia, and then we can inject it. If you don't have it's zipped 360, you are up to perform membranectomy there locally and then inject your viscoelastic underneath for dilation. As we said also, always be aware of pupillary membrane that are occluding the pupil. So usually the pupillary membrane is easily removed at the time of posterior synechulitis. However, in some cases of prolonged inflammation, it could be tricky. So take caution about that and the possibility of bleeding, iridodialysis with the forceful manipulation. Once an opening in the membrane is made, you can use your retinal scissors, can be used to remove the membrane. So utilize your tools to the maximum. Utilize your iris retractors. Okay, and inject also epinephrine, migraine, whatever you can to dilate the pupil as well. Be aware of the fibrotic anterior capsule, because most of the time they have a very thick plug-like on the anterior capsule that are leaving the capsule at risk of tears. You can have a tear, you can have an Argentinian flag right from that like a plug on the anterior capsule surface. So sometimes you have to also counsel the patient prior to the surgery that there's a possibility of aphakia to control the inflammation. Sometimes putting an IOL could be more dangerous and more harmful to the eye rather than leaving the patient aphakic. Now, this article was suggesting that always avoid the accommodative IOLs, and those will never settle, or even toric IOLs. They will never settle in eye that is vulnerable for inflammation. But use a 3-piece. They recommended the use of a 3-piece because even if it migrated at some point, it can be easily sutured into position later on. Okay? And remember that the end of the surgery is not the end of the entire story. You still have to follow those patients because they can have still having high IOP after the surgery, or even need a glaucoma procedure later on. All right. So in summary, the glaucoma is a frequent complication of uveitis arising from inflammatory disease process itself or from the steroid administration. So this is the take-home message. And uveitic glaucoma can present via different mechanisms, and the treatment should be first directed at the treatment of inflammation and the underlying systemic disease. Uncontrolled intraocular pressure is often managed with glaucoma medically, and reluctant cases sometimes require surgical intervention, with improved long-term success rates reported with glaucoma drainage devices over other modalities. And that's it.